Hello, everyone. Welcome to our continuing webinar series focused on addiction, prevention, and recovery. My name is Kevin Burns. I'm Chief of Staff for General President Eric Dean, President of the Ironworkers. As many of you are aware, General President Dean and the Ironworkers are very passionate about this topic. Past impact webinars, like No More Prayer Cards and A Culture of Caring, align perfectly with what we're going to hear at this webinar today. Today we have John Greenwood, co-founder and chief operating officer of Goldfinch Health. The Impact Board heard his at a meeting recently and decided a wider audience needs to be heard about Goldfinch Health and what they want to convey to us. Before we go before I turn it over to John, I have a few housekeeping items. We're going to monitor the Q&A box, which is on the bottom of your toolbar. Don't hit the chat button. We're only going to be looking at the Q&A box. This webinar is being recorded and will be posted on the Impact website. Presentation slides will be uploaded to the Impact website. We will present for about 20 minutes, 20 to 30 minutes or less, and then we're going to leave some time for Q&A questions at the end. And remember, register for our live annual conference, February 12th through the 15th in New Orleans, Louisiana. We got a great agenda. We're looking forward to seeing everybody at our Impact Conference. And with that, I'll turn it over to Thank you.
Thanks so much. Appreciate it. Appreciate the opportunity to speak with something that's near and dear to my heart about what we can do to help members who are encountering surgery and are concerned about opioids. There's a lot of conversations around what happens when you're already exposed to opioids or perhaps already addicted. And maybe you're concerned about that, or maybe you already got over or are battling with an addiction every day, and now you need to come into surgery. You've got to get that shoulder repaired. You've got to get your knee replaced. What do? You feel like you're going to have to either have a dance with the devil and either be in a lot of pain, or you're going to take those opioids and risk the addiction that goes with it and all the additional challenges. So what we're here to talk about today is that you don't have to choose, that there really is a very, very strong solution here. And we hope to encourage and arm you with the ability to advocate for this alternative experience when going through surgery, because really surgery can be either an inflection point where we help you resolve that pain, or where you get exposed unnecessarily to opioids. The latest science is really incredible, and I'm excited to chat with you about what that means. And just a quick background on myself. I'm in Iowa City, Iowa, and as Kevin was mentioning, I co-founded Goldfinch Health about 4 years ago because I was seeing what was happening in surgery and knew that there were alternatives and knew there were better ways, but just people weren't likely to get it. My background is in research and pharmacology, pharmacokinetics, and some telemetry. And then I spent a decade training surgeons on minimally invasive approaches in surgery, participating between 4,000 and 5,000 operations, best I can tell. But December, 7 years ago, my uncle, who was actually a mediator between ownership and unions as a consultant, he went in for his hip replacement. My uncle, I'm not sure how I was related to him, but he actually was a Harvard PhD, and I thought he'll be totally fine. And unfortunately, he was not. Like so many others, he kind of trusts what's going on and caught a hospital-borne infection and actually passed away in the hospital 8 days later from a very routine procedure. And that was one of those days that it shocked me what this experiences were like for people when they're not getting state-of-the-art care. And actually, you can see, I bring this picture up too, because just recently it's hit home even more so why I'm so compelled to help people with better surgical experiences and avoid opioids. My son on the right, he was born 2 years ago in April, kind of peak panic of the pandemic. And he's doing great, and he's the greatest little guy ever. He's so sweet. You can see with that infectious smile. But he's needed 5 operations on his skull. He doesn't have a right eyelid, and he's needed major skull and bone operations. And I'm seeing time and time again the reliance of the healthcare system on opioids. When it's not good science, it's not good pain, it was great marketing to get us here from the from the Sackler family in Purdue, but that's not really what the best way to go through surgery is. And these surgeries, as I was describing with my uncle and even with my son, have real consequences. It is that 90% of procedures are more invasive than necessary. It's the number one gateway to opioid addiction. In fact, as you saw likely on the header, 30% of all opioids are not, it's not written by chronic pain physicians. It's written by orthopedic surgeons, not to mention all of the other surgeons that are out there writing prescriptions. And it's not necessary. And so we bring up one more personal story, or one more story, and that's relevant to impact. This is actually a union construction worker who was going in to get his shoulder replaced, and he got a world-class NBA physician that was going to be doing the operation. But they were still going to be doing it with the traditional approach, using opioids as the primary way to treat his pain. And we got involved. My company, of course, is Goldfinch Health, but we want to encourage you to advocate for your own membership and yourselves and your loved ones. Because when we got involved with our nurse, she was able to reach out to the physician, get him on the phone with the patient, and talk to him about alternatives to opioids. And I'll get into what that really means in a second. But alternative medications. And the physician said, yeah, that's fine. We can do all of that. But you got your OxyContin, right? And the patient said, yeah, no, I got that prescription. And our nurse was the one that really encouraged him to have the conversation. And she said to mention to the physician about his experience. And he said, yeah, but the patient said, I'd really love to avoid it. My dad is a electrician. And when he replaced his knee, he spent 2 years addicted to opioids. And our relationship still isn't the same. And there was like a gasp on the other end of the line from this physician, because it never occurred to him to ask those questions, to see if there were alternatives. And his response was very humble, and I appreciate that physician's response. He said, you're right, it's a very good thing we're doing these other things then, isn't it? And to that physician's credit, he updated his care protocols, and that patient at 3 weeks was off restrictions when he had originally been told that it was going to be a 3 to 5 month recovery. When you optimize a patient and you use the good science, not only do you dramatically reduce your opioid exposure. By the way, this individual with the shoulder surgery, most complex joint in the body, usually a very painful operation, used 2 opioids total on his recovery. They had written him 60 to begin with. This is just a better way to get through surgery, recover faster. Just a real quick conversation too on the challenges we're all facing when it comes to encountering our healthcare. Not only are things like colonoscopies down, mammograms are down, but what we're finding is that escalating healthcare costs related to inflation and the opioid pandemic, we now have all of those delayed procedures coming on board. So the ability to get your physician's attention or your nurse's attention becomes much more challenging, and we all need to be working. We're not sure what's happening with the economy. We all need to be getting as many hours and as much into our savings as possible. And we have labor shortages. What have we experienced? What have we seen? We've learned a lot more about opioids, but yet we've seen, due to the pandemic and all of the challenges of delayed operations, in a recent study looking at knee surgery showed an increase in opioid prescribing by 40%. And this shows up in our Taft-Hartley data. This is actually from one of our clients in the upper Midwest and the Chicago area, where we looked at their data and were able to see that their musculoskeletal procedures pre-pandemic was down 18%. And but what's happening is that these aren't just going away. We're not just operating less. These aren't superfluous operations. They're getting more knee injections, more steroid injections to delay their care because that surgeon's booked out 6 months, or because we can't really afford to have any additional time off. We're just kind of kicking the can down the road with these steroid injections. And by the way, we may think these steroid injections are a really good solution. The reality is they don't work for very long. In fact, they eat away at your cartilage that is remaining with those steroids. So it becomes a challenge that we're all facing. So beyond kind of the setup or the concerns, I'm going to take you through a traditional approach through surgery that you all may recognize or at least understand and can envision. And then I'm going to stop complaining about these problems. I'm going to start talking about the incredible solution that is out there that really can help people not only recover faster, reduce their readmission and complication risk, but dramatically reduce their need for opioids. And this isn't about grinning and bear it. This is about improving the patient's health so that they can bounce back much, much faster. And so if you know anything about surgery, I'm going to take you through the stress of a traditional approach through surgery, both your physical stress, your physiological stress, and the mental component that goes into it, which is very, very important as well. And so more stress is down, just makes more sense visually. But if you know anything about surgery, you know you can't eat or drink anything the night before your operation. They don't want anything in your stomach that can get into your lungs when you're sedated. We get it, but it is absolutely terrible advice. They don't trust you to know the difference between a donut and a glass of water. So we just tell all patients, don't eat or drink anything. Well, what's going on now in your body? Not only are you dehydrated, you're hangry, you literally have a lower pain threshold, but that hydration and that lack of calories has a lot of problems to your body. It wreaks havoc. It induces what's called insulin resistance, which basically is your body in the fight or flight mode, protecting your vital organs because it doesn't know when your next glass of water or calorie are going to be, you're going to get those. So it's protecting your vital organs and not delivering a good care to your knee to help you start repairing earlier. In fact, we'll get into a little bit more of the benefits of this, but this is based on a bad study from the 1940s that said maybe we shouldn't let anybody drink anything. And that's still how we're applying today. You as a patient, when you are moving on to the next portion of the concerns, you as a patient are likely to get the procedure that your surgeon that you've met, perhaps your only one surgeon, knows how to perform. Not necessarily what's best for you. In fact, you're far more likely to get the type of technique they learned when they graduated from their residency program, not what is necessarily least intrusive, least invasive, least traumatic to your body. And so helping a patient understand, asking the questions, is there a minimally invasive approach? Is there a small incision approach to this procedure to avoid the rather large incision, which is still occurring about 60% of the time? And what happens after your operation? We wake you up. We've given you medicine called Versed that makes you forget things. We give you all these really important instructions. We give you a bunch of opioids and we send you home and we say, we'll see you in 2 weeks. Good luck. Addiction and withdrawal symptoms set in 3 days. I can almost assure you your prescription is long enough to get you through that 2-week period. If you take the prescription as instructed, you will experience withdrawal symptoms. That's how sinister this current situation is set up. And it manifests itself in things like 108,000 overdoses annually. 20% of total knee and total hip patients still taking opioids 3 months later because your doctor gave you the medicine to do it. In fact, there is a stronger correlation, a stronger connection to how many opioids you're taking. The amount of opioids you're taking has a stronger connection to the amount you're given by the doctor than how much pain you're in. It's really a very, very poor setup for surgery. So again, I promised I'd stop complaining about this. You all know the challenges that we're facing. The great thing is this is the solution. This is a really wonderful experience about first dose exposure, first dose prevention, and it's called Enhanced Recovery After Surgery, ERAS. If you're taking any notes or you want to Google this, please do. I don't frankly really like the name of it because it implies it's after surgery when a lot of this is about preparing for surgery. But ERAS has been around for over 20 years. There's 4,000 to 5,000 articles on the merits of this published just yesterday. One was published in Journal of American Medicine, and it's Johns Hopkins and Michigan, and we're publishing all the time on it. It was very poorly implemented. But what is ERAS? It puts the patient at the center of every surgical decision. The most important person in the OR is the patient. And I'll explain a little what it is. So there's about 10 or 12 of these small little things that add up in a big way, and I'm just going to talk about 3 of them. The first of which, instead of don't eat or drink the night before midnight, don't have anything in your stomach, the better way is a Gatorade or a clear carbohydrate beverage like this. It's called CF Pre-Op. That has been shown to be out of your stomach in 90 minutes. So you don't get anything in your stomach, or you can't get anything in your lungs. In fact, it's so important that it reverses all of those other things I've talked about. But Harvard did a study just looking at Gatorade, or that clear carbohydrate beverage. They took 400 total knees and total hips. They gave half the patients a Gatorade, and the other half, they said, don't eat or drink anything. And the people who got a Gatorade left the hospital a full day sooner. They were up and at it. They were able to walk further. They did more physical therapy, because we stop pretending like your nutrition doesn't matter, and we start figuring out how to optimize you. And when you do that, it's incredible at how much you can bounce back from. Another way to optimize you, and this gets to the heart of this conversation with impact, how are we actually treating pain better without opioids? And it's a big mouthful, but a very simple concept. It's called preoperative multimodal analgesia. So multiple methods of non-addictive, non-narcotic based pain medications given to the patient. Here's the really revolutionary part: before the procedure even begins. I have family in the military. When you go into a forward operating theater, you'll take a pain pack just in case you experience trauma. You have that on board. I guarantee if you're going into surgery, you're going to see trauma. Why we don't apply that same logic is beyond me, but ERAS does. In fact, I'll give you a quick example of what this really means. You're supposed to get ahead of the pain, stay ahead of the pain, but it's not when you wake up, you regain consciousness after your operation. That procedure, your body has been in a 5-alarm fire for the last 3 hours. So the idea of giving a patient Tylenol with your Gatorade the morning of your operation. Another drug that's just like ibuprofen, it's an NSAID called Celebrex that doesn't interfere with bleeding. There's another one that quiets your nerves. There's long-acting injectables that are just kind of like Novocaine, but they last for a couple of days. Before you know it, when you've taken those medications before the procedure began, you basically tell your brain, we got this, we'll be okay for the next few hours. You've dug a much shallower stress deficit. You've optimized the patient going into surgery. So when you come out of it, you have a much, you don't have to rebound nearly as far, and an emphasis on Tylenol and ibuprofen. We found that most people don't know those are totally different drug classes. In fact, we did a survey, only 8% of people know that Tylenol is different than Aleve and Advil and Excedrin. When you emphasize taking those two together and you alternate them, a recent study showed that is 3 times more effective at treating your pain than oxycodone is, what people will call the good stuff. So by getting ahead of the pain, staying ahead of the pain, alternating it with these non-addictive medications that actually treat the pain, you can do better. You don't need to go back to the hospital. You're not in as much pain, and you can do it without opioids or with very few opioids. And it also helps you recover and get back to your job in half of the time. In fact, what's all this manifest for? We're showing that patients across the board are recovering over a month faster. This has actually been independently validated and audited. 32 days faster recovery when compared to the national benchmark. A 92% reduction in opioid refills and the amount needed. And by the way, what's the worst thing that can happen? Infections, readmissions, complications, less than 2% readmission rate. I want to give you a quick example. We're not cherry picking.
John, let me stop you there for 1 minute.
Yeah. Mm-hmm.
So I just want to remind our audience that may have come on a few minutes late that in the bottom toolbar, there's a Q&A. So as John's presenting his slides, if you have any questions, stay away from the chat bar. Please go to the Q&A. Thanks, John.
Perfect. Thanks, Kevin. Yeah, please. Even if it's to share your own experiences, please bring that on. That can help others as well. But I want to emphasize that this is really an incredible solution. These enhanced recovery is an incredible solution for people who are even already on opioids. We did a recent survey of patients that our nurses were helping in the highest risk category. People on opioids going into surgery are the highest risk category for persistent and long-term use. So what we found was with the advocacy and support of the nurse and ERAS implementation, that those patients, the highest risk category, filled 1/17 the amount of opioid refills. Not only are they taking less of the prescription, but they don't need to go back. You're done with your operation. You're done with your operation. You're able to put that behind. And I'll give you just a quick example. This is not cherry picking. This was a total knee replacement. There's not a minimally invasive approach for this. This is a big incision, and this individual just looks like and what any of us could look like, not a world-class athlete. and not a 20-year-old. He comes in with his cane, but this individual is 2 weeks after his operation. This is the first visit with this physician. And mind you, the 20% of these people are still on opioids after 3 months. I want you to see what happens to him when he gets up. Yeah, doctor asks him to get up. The average recovery for something like this is, again, about 3 to 4 months. It's really, really remarkable. The challenge is that these are not well implemented. There are societies out there, there's multiple physician societies out there that are doing all of this research and are largely, it's an academic discussion. They get together and they talk amongst themselves. But the power, ultimately, what a union is to be able to come together and drive change, not as an individual. An individual patient walks in, they may or may not get changes to this, but as a collective with that impact, that ability to address the healthcare market, that address your physicians and say, hey, we demand this. Hey, we're tired of being unnecessarily exposed to opioids. We're tired of being out too long. We're tired of the challenges that come with this. We're expecting this and we're demanding this because it's really ultimately your healthcare. It's the patient's body. They should be able to ask for these kind of things. So I wanted to kind of talk a little bit too about what you as the individual can do, not only for yourself, but if you have the ability to influence for your membership and for your plan. Really want to just encourage your patients to speak up about alternatives to opioids. There are really great non-expensive drugs out there that cost a dime that can be given to the patient to dramatically improve their outcomes and perhaps even save their lives. That's our chief medical officer is a general surgeon in Albuquerque, and he says that the only thing that gets a physician to sit up straighter than a complication is a well-informed patient in his office making a reasonable demand. That is a huge component to advocacy. It's just asking these additional questions. What alternatives do we have? Speaking up. There was another recent survey showed that 80% of people are concerned about opioids and surgery. I think it should be 100, but 80% admitted to it, but only 20% of people actually have a conversation with their physician about it. There's also the ability to speak with your plan about some more high-level strategies around support and opioid-sparing strategies, such as we've really relied on at Goldfinch, the nurse support. So there's someone on equal clinical stature that the best analogy I can come up with is a lot of times in this tennis match you're in with your surgeon, they hit 100-mile-an-hour serves and you're just trying to get out of the way, just like that patient Mitch we were talking about. But by having somebody, an advocate or a nurse or a family member or perhaps you, that hits that serve back and realize that this is a conversation and not a didactic, and you're not going to get that rubber stamp experience, but that you are a unique person and you're going to get a unique surgical experience, that has a tremendous impact as well. We also have put out at goldfinchhealth.com, you just go to the patient portal, 10 questions to ask your physicians. You can walk in. If you go to your physician's offices with those 10 questions, you are already in the 99th percentile. And one other thing that I think can be of interest, we provide our memberships with care kits. This is that clear carbohydrate beverage, emphasis on heat and ice, a few other things. But I'm a huge fan of these doTERRA packs as well. These doTERRA packs are not expensive. They're basically carbon that you put your leftover opioids in, you add water, you shake it up, and it denatures the whole opioid so you can throw it in the trash. Not only does this give you something you can do with it, but we've shown, studies have shown that physicians write less opioids and patients take less opioids, because it's almost like saying, okay, here's your opioids, but it needs an antidote. This is kind of serious stuff, so make sure you throw it away. You can't just throw it in the trash, and make sure you don't hang on to it. It's a little bit of an additional alert that these are potentially challenging medications to deal with. What it really fundamentally comes down to is that opioids are not good at treating your pain. They are good at helping some people feel a sense of euphoria or ambivalence towards your pain. This kind of goes to the science of it and the mu receptors of your nerves. But when we get away from how the $100 million a year marketing budget that Purdue sunk into changing physicians' minds for the worse, when we remove ourselves from that and we apply the really great science around how to treat and tackle your pain at the source and with your spinal cord and locally and with your perception of pain, there's a really incredible way to come through surgery. And I'll kind of end with this. This was a patient that we helped with our checklist, but I'm going to end with a personal story. When my dad saw my son after his operation, and he's unlucky in some regards, but he's lucky in that his dad, this has kind of been my career to help advocate people through surgery. He's a very tough guy. He said that as he was getting choked up, it was the closest thing he's ever seen to a miracle in his life with my son's 9-hour frontal orbit advancement and craniosynostosis to really reconstruct his skull. And I kind of paused and I said, well, actually, I started to talk to him about all the things that we had done around enhanced recovery and preparing him. And I just paused and I realized he's absolutely right. Surgery in 2022 is incredible. It is miraculous if you can get it. You're not likely to on your own. You need to encourage or get an advocate or be that advocate to encourage upgrades, to encourage preoperative alternatives to opioids, and making sure after that operation you're taking Tylenol and ibuprofen as the first 2 lines, and then maybe an opioid if you still need it. Because the science is settled. This is an incredible way through surgery. We can do amazing things. We just apparently need the patients to demand it and encourage the physicians to upgrade their practices. I think you all can help with that. And I'm certainly here. I wanted to leave my number or my email address. If anyone wants to learn more, please reach out. But at the very least, we're working on a movement here to help drive alternatives to opioids, improve surgical outcomes, and get people back to their lives.
Well, great, John. Thank you. We do have a couple of questions out there, John. Number one, let's play devil's advocate. Put yourself as an iron worker that goes into an emergency room. The majority of times when an iron worker gets hurt on the job, it's obviously a workman's comp issue, right? Yep. So my question would be, how does an iron worker that gets hurt, how does he advocate for themselves? And is there a difference between a workman's comp doctor and just a regular doctor in an ER, in your opinion?
Yeah, they're very, I mean, they're all orthopedic surgeons at some point. So the other thing is too, being able to rely on your plan that doctor is going to see several of those workers, and the expectations are that, that there will be upgrades for you all. So I'll just boil it down to exactly what your question is. If I'm going into if I'm going in an emergency procedure, now usually you still have a few days, but if it's an emergency procedure, notify them of your concerns of opioids. What can we do to ensure that I'm not unnecessarily exposed? That gets physicians a substrator. I have it in my family. We have addictive personalities. I'm 20% or 10% of all adults in this country suffer from substance use disorder. It impacts a lot of our families. Asking very specifically on the nose, I want to avoid opioids as much as possible and not be in extreme pain. What can we do now to ensure that? That is a question that doesn't get asked, and I promise you that will get the physician to pause. And don't let them brush you off like you'll be fine. That is their cognitive dissonance. The asking for Tylenol and an ibuprofen and a long-acting injectable before the procedure begins will already put you in a different echelon. So I think that there isn't enough awareness brought from the patients to the physicians of their concerns around opioid exposure.
My other question would be to you is, look, I'm a believer in Goldfinch. I think everything you sense to me. I've had minor surgeries, knock on wood, nothing big, but I remember saying, hey, nothing by mouth, so you go into these surgeries dehydrated. And then of course we've all had, just a common thing like getting a bruised rib or something. The doctor goes, well, let me give you a script for pain. And you say, no, and he goes, well, if you need it, here it is. And we know what that translates into, right? Right. Even if you get the script, you keep it in your medicine cabinet, you got kids at home, a party, data shows that a lot of these scripts are being, when your kids are home, your teenagers are there and someone comes into the house, facts are that someone could get into your medicine cabinet. So you showed your disposal kit there a while back. I think a lot of us are guilty of, right? A lot of us are guilty of keeping old prescriptions, in the medicine cabinet in case something happens, that type of thing.
Right.
So can you explain how we can get a hold of those? I mean, I know we could probably get them through an impact grant, but.
Yep. Yeah, no, that's great. And that's exactly right too. And doTERRA was started with a grant from the National Institutes of Health. It's a great stuff. It's an emphasis on it because you're right. At best, these leftover opioids go into the water supply. You might flush them, which is, it doesn't, now it's just in our water supply and it's not really broken down. And yeah, if you leave it in your home, studies have shown that each 10 more doses of opioids impacts the rest of your family more than even the patient. Yeah. So that's what's happening. It's my cousin. He's a union tile layer in Omaha. He spent 15 years addicted. He's 18 months sober, but his life will never be what it could have been, except he was exposed to diverted opioid pills. We've launched a separate portion called Beyond Goldfinch, because we're so passionate about this project, called the Billion Pill Pledge, that there's over 3 billion leftover pills after surgery each year that you might be self-medicating. Or something happens, now you're all of a sudden a doctor and you're just prescribing yourself, Percocet. That's not great either. And so we believe that with the doTERRA packs, which I would encourage to even have on job sites or to hand out to people, we believe with smaller prescriptions, with alternative medications, and with the doTERRA packs, that we could remove 1 billion opioid pills from our medicine cabinets annually and kind of create a better paradigm shift to the advances in treating pain instead of relying on the crime of the decade, perhaps the crime of the century, to treat our pain.
Great. So I think you've given a pretty good analogy about how we have to be our own advocate. So, we have a lot of people from labor, people from management on this webinar. And I think early education, I recently gave a talk to some of the apprentices and coordinators saying that, look, anyone that comes into this business, that there is a probability that over a 20 or 30 year career, you could end up in an emergency room for a sprain, a back. Hopefully it's something minor, of course, but being your own advocate and having those talks with the doctor. If you, like John said, if you have a family background of alcoholism or substance use disorder, or you have a brother or a father that went through something, let that doctor know. Say, hey, look, I don't want to go down that path. So you work with me and prescribe something that's, it's not going to be a narcotic. Why don't you talk a little bit about how the body can heal itself,
Yeah. So, and I could say too, we're spreading the word on enhanced recovery too. And of course, Goldfinch, we're working with, IW7 and several others to help the nurses to become those advocates, because I know it's sometimes challenging as well. So that's why we hire nurses to be on equal clinical stature. But it is really about understanding the science of how your body perceives pain and responds to pain. What's happening with an opioid is it's hitting what's called the mu receptor, which kind of gives you this sense of euphoria, or kind of that ambivalent feeling, that indifferent feeling to the fact that you're in pain. And these are related to opium. It's related to heroin. It's not specifically designed for your pain. But a medication like Tylenol literally works. It crosses your blood-brain barrier. It works on your spinal cord and your brain, just to quiet those nerves down and to make sure that you're not getting that extreme signal. That the class of drugs called NSAIDs, which is like ibuprofen and naproxen, which is Aleve, and this drug called Celebrex, which I think is a really, really great drug. It actually works at the site for inflammation. So it prevents your body from getting into this really alarming cascade. And people might say, well, inflammation is natural. And yeah, there will be some. And you want to feel a little bit of pain because it's telling you to take it easy on that new knee. But surgery is not natural. And so by being able to say, okay, there's a medication here that kind of modulates that inflammatory response, then now we're treating a different way through pain. We all go to the dentist, you feel fine, you feel a little bit numb. There's medications like that last 2 or 3 days that literally block those nerves. And so you start to see, I've now talked about 3 or 4 different drugs and a gabapentinoid, which makes your nerves not quite so loud. I've talked about 4 different drug classes, and not one of them have I talked about an opioid. The challenges, and I speak in simple terms with the physicians and demand that of them, because healthcare is intentionally opaque. It's intentionally difficult to understand. I'll give you a quick example. Toradol, Tylenol 3, and Tramadol are all 3 different pain meds. 2 of them are opioids. And by the way, the Tylenol 3, that's one of the opioids. So by being able to ask the doctor to speak in simple terms, I want non-opioids and I don't want to feel like I'm in a bunch of pain. What can we do before the procedure begins? I'm telling you, that puts you on a different esteem than a lot of the traditional patients that just go through and become, feel like they're just kind of run through their numbers and they're getting a traditional experience, which is not going to result in the outcomes that that patient deserves.
Thank you. Got a good question here. It's guy gives a situation where a good friend of his is hips and knees are hips and knees are being replaced commonly. And obviously, if you're in a construction field for 20, 30 years, you know, it's not uncommon to have a knee surgery or hip replaced. So why is there such a difference from surgeon to surgeon? And why do you think the American Medical Association hasn't embraced this more, you know, to say this?
Yeah, there's some great questions in there too, and I'll just start with kind of your last question too, and that why it hasn't embraced a little bit more is that change is very hard in healthcare. You don't want to be experimenting or trying something new with a patient because it is a patient and they have to live with the consequences of those decisions from the physicians. But that becomes its own problem then when a physician totally refuses to update their practices or is concerned about getting calls in the middle of the night because you're in pain because they didn't write you enough opioids. It's called implementation science, and it's very, very challenging once a physician has kind of gotten in their routine to get them to change, even when there's overwhelming evidence. So it's kind of one of those things that it has a strong foundation of not being too loose and fast with your decisions, but it becomes a really challenging consequence kind of on the back end as well. So, and you were asking about, you know, the quality of the physicians, and that does matter. That does matter. We kind of, you know, there's the joke, what do you call the person who graduates last in their med school class? Still call them doctor. They don't have to be your doctor though. That's why I think even on the chat too, those are really great questions. Asking people in your lives about great recommendations, about minimally invasive approaches. It's funny because we oftentimes ask doctors who they would recommend, but they've never operated with other doctors. They're in fact the one person in the OR that doesn't have any or has minimal cross references. So the Zimmer rep was a perfect example. I've relied on Zimmer and Stryker and Ethicon and Intuitive reps for my family's experience as well, because they work with all of those physicians. But really what it boils down to is making sure that the patient is the best version of themselves. Making sure the most important person in that operating room, that they are superior, is that patient. When you optimize them, you can handle a lot more variability in the physician's expertise. And don't be afraid to get that second opinion. We just were working with someone in North Carolina who was told by their physician that they had lung cancer and that they needed to have a rib removed and an open operation. And we asked them about minimally invasive approaches, and she said, "You're not a candidate." And the patient worked with us to get a second opinion. That surgeon, she was right, was not a candidate for a minimally invasive approach in her hands. But another physician who does small incisions with a robot and does 3 of these a week, has done thousands of them, she absolutely was a minimally invasive candidate in that other physician's hands. So if you don't like what you're feeling, you get that vibe, I encourage you, ask for that second opinion and encourage those around you who have worked in the operating room for those references and minimally invasive approaches.
Very good. A couple more questions if you have time. So one question comes in. Thank you for this information. Are there any suggestions union leadership, apprentice coordinators, and members can obtain information and training associated with these alternatives, concepts to help market this within our industry to bring about awareness?
Yes, please. I would just encourage you to follow up with me on it around the Billion Pill Pledge, our 10 questions to ask, the efforts we're working on with Goldfinch, educational material. We're absolutely on a mission to help people get great care. And that might be a broader conversation, but I'll give you one quick example. Next week on the 11th, for our current membership, we're hosting a webinar just like this to anybody who's considering surgery, wants to jump on and find out what questions to ask or perhaps get a little bit of advice. We're bringing our chief orthopedic officer, Dr. Vinod Dasa, who's adjunct professor at LSU. He's the one who operated on that patient with the knee that we saw. And he's going to talk a little bit about how you can get a really a 2022 version of surgery. Great question.
One of the other questions we just got, do we have any plans to roll this information out to people? Has there been any media procured yet? How do we get people out of wanting the good stuff versus using things that work? That's a good question. I mean, to go into an operation, asking or wanting, oxys or the good stuff. I mean, obviously that's kind of a self-destruct mode in my opinion, but how do you answer that as far as any media out there yet, John?
Yeah, so we're working on that. Actually, we was just telling Kevin, we're getting our first opioid settlement grant to help with driving awareness and working with hospitals around the Billion Pill Pledge. But I would encourage, it's just kind of things like this. And again, it's a similar question to the previous one too, about if you want to follow up with us on the methodologies and the material that can be disseminated and the questions to ask, just like that, for instance, we can get, I was going to try to pull up, but that last checklist, that was a patient that we provided them a checklist to go speak with their physician and fill out with them sitting in front of them. That is when physicians start to pay attention to as well. So great question. If you want to follow up after, we can get you some of that material. At the very least, I encourage everyone to perhaps print out the 10 questions to ask or email out the 10 questions to ask your physicians to your membership.
We had one person just had a kind of a comment that he had recent surgery and got 6 shots of Eprenol, and it was a game changer. Stayed off of opioids and really, helped his recovery quite a bit to get, and stayed off the narcotics.
Yep, wonderful. It is. I'm not here to tell folks that you have to choose between being in pain or warn you on the dangers of opioids around surgery. Surgery is a traumatic event, or it is a intense event in a person's life. But I am saying that there are really great alternatives to this. And the idea that we shouldn't be in pain, or that pain is the 5th vital sign, or we want to treat you to zero, to be in zero pain. That again is straight from Purdue marketing playbook. You really don't want to be in bad pain, and you don't want to be in even moderate pain. But by being able to treat them with non-addictive pain medications at this time when so many people are exposed, it's really a grassroots effort is what's going to do it. And that's why I'm excited to speak with you all about it, because there's such a collective basis of well-intended, well-informed people. And just like these questions saying, what can we do for our membership? Those are great questions to be asking. And I think providing the 10 questions and education and following up would be a wonderful place to start.
Great. Well, I think that wraps up the questions, John. Really appreciate your time and what Goldfinch Health is trying to assist our members with. Thank you personally. I've got to know you pretty well, and I know you're passionate about this whole thing and passionate about helping not only people in the building trades, but everybody that's going to hit in surgery. Have you ever had any references, like with someone in an emergency room says, "Hey, I have a company called Goldfinch Health, doctor. Are you aware of them Are you aware of them in the operating room? Can you use their methods with me?"
We had just a recent patient who was a previous patient, and then went over their handlebars on a bike and thought they shattered their wrist. And when they went into the ambulance, all they had was fentanyl. And she said, "Well, can I have ibuprofen and Tylenol?" And they said, "We don't carry that." And so she read the Riot Act and Actually, they're working on trying to get that in, or working on getting that as a standard approach at that hospital. So that one last quick example, it's worth bringing up. We had a patient who was, you can impact that change too, as just as mentioning in that ambulance example, but had a patient in Omaha who went in for a shoulder surgery. And they were a bit resistant because sometimes physicians will say, I don't know, this is new. But they were persistent and had our nurses help. And at the end, they said, well, you need to take this good stuff, which I hate that terminology, but that's what they said, you're going to need it. And the patient came back and said, actually, when my wife took the prescription as you prescribed, she showed up in the ER with an overdose. I suggest you stop telling that to patients. And when he went back, he got really great results, took one opioid one day. When he went back for the other, they had totally changed their surgical protocols. So the ability of one person who's well-informed to impact, it exists out there. Physicians are people too. They will listen and they will change when patients are demanding it. And we have many, many examples of times like that where now, because that one patient brought that to their attention, how many others in the community are benefiting from that major orthopedic office changing their protocols to reflect the updates to surgery. So you can do it, and we're here to help, and we'll share my contact information if you want to follow up as well. So thanks for the opportunity and thanks for the time.
It'll all be on the Impact website Monday morning. John, thank you very much for today's webinar. And I want to just shout out to CEO Kevin Hilton of Impact, who was instrumental in getting you together here and putting this together. And I want to recognize General President Dean, our labor co-chair of Impact, and Bill Brown, the management co-chair. Thanks for what you do. And obviously, we're in this passionate. You can see this this month's magazine, Stigma. General President Dean has a good article on it. And I look forward for seeing everybody February 12th through the 15th and at the Impact Conference. So go on the Impact website and register. Thanks, John. Appreciate you. Take care, everyone. Thanks again for signing into another great Impact webinar. Have a great day.